Hi, my name is Dr. Maegan Lubbers. I'm an OBGYN. I currently work in Florida. I've been part of OBHG for about 8 months. Previously, I was a private practice physician in Florida for about 6 years. And I'm going to tell you about a patient who I had during a recent shift. So at our facility, we change shifts around 8 a.m. in the morning. And so 8 o'clock I came in. There had been a patient that was ready to go for a C-section. She was a 26-year-old gravid of 1 at 41 plus weeks who had been admitted 3 days previously for a scheduled induction for late-term pregnancy. This was a patient who had undergone multiple rounds of misoprostol for an unfavorable cervix and then had progressed in labor and underwent Pitocin for several days. Overnight, she developed a fever and was diagnosed with chorioamnionitis, and she was started on antibiotics. She then progressed to complete dilation and at 2 a.m. started pushing. She pushed for about 4 hours. Decision was made to proceed for the C-section. However, the patient didn't have an adequate epidural at the time, which had to be replaced. When I came to the shift, this patient was ready to proceed with her C-section. We were concerned because of how long she had been pushing, worried that it might be difficult to deliver the head. Also, we were concerned about her chorio or infection and the amount of uterotonics that she was on and the duration of time, increasing her risk for a hemorrhage during delivery. Luckily, when she went for the C-section, the head was not very engaged, so it wasn't very difficult to deliver the baby. However, she did have uterine atony, or the uterus was a little bit boggy, and was probably just tired from days and days of medication and the infection. So as expected, she did get multiple uterotonic agents. We gave her Methergin, we gave her Hemabate, she underwent TXA. And at that point, her uterus was firm and responsive to these medications. Her intraoperative blood loss was only 500 to 600. After she had gone to the recovery room, however, I did get a call that her bleeding had increased. And upon evaluation, we gave her 1,000 micrograms of misoprostol rectally. Unfortunately, upon evaluation, the lower uterine segment remained somewhat boggy. And at that point, the decision was made to proceed with a JADA. Now, a JADA is a device that is kind of like a suction for the uterus, and it kind of collapses the uterus down. So the goal is to prevent that lower uterine segment or the uterus just from being atonic and not having that nice contractile function. The JADA device was employed and at that time was placed on suction as per the package directions. We continued the suction for an hour. At an hour time, we discontinued the suction device, monitored the bleeding for the next 30 minutes. And at that time, she only had about 30 cc's output. Of note, her entire estimated blood loss at this point was 12 to 1,300. After the JADA device had been monitored for about 30 minutes to an hour, we discontinued it and removed it entirely. And the bleeding was very mild. Post-operatively, this patient did great. Prior to her C-section, her hemoglobin was 9, which is already a little bit low, and it did dip to somewhere in the 7s post-operatively. However, she remained asymptomatic for her anemia, so she did not actually have to undergo a blood transfusion, and she was able to go home on post-operative day number 2. I think this patient was somebody who we knew was going to be a challenge going into the case because she had all the risk factors for an operative hemorrhage and postoperative hemorrhage from just the prolongation of her induction, her infection. She was kind of a setup for that. However, we were ready. We were able to have all the medications already in the room and prepared. Postoperatively, it was advantageous to not be in private practice. I've previously been in private practice, and there's always a concern because you go back to the office and then somebody can be hemorrhaging and it takes you 5-10 minutes to get there and evaluate. And you can do the uterotonics, but at the end of the day, if you have to do a device such as a JADA or a Bakri balloon, you still have to be there. And it was nice because I was right there. So not only could I give the device, but I could closely monitor it, not have to be pulled between two different places at the same time. So that was a big advantage. And I think that our ability to respond so quickly and be there on site is what prevented this patient from further morbidity. She didn't have to undergo a blood transfusion, and she's remained stable throughout this entire process. I was very pleased and very happy just with our ability to respond quickly. And again, coming out from private practice, not being pulled to and from the office, having that concern where you're trying to cross multiple lanes of traffic to get in to see a acute patient from the office was a huge advantage.